In cases of transscleral IOL fixation, using a needle for externalization of haptics or sutures, we potentially encounter several difficulties. One problem might occur if haptic and needle are positioned with a suboptimal working angle. Even with thin-walled needles, sometimes haptics or sutures do not easily glide into their opening. As you can see here, the haptic stops and bends, risking damage of the haptic. Additionally, the haptic is not fixed inside the needle and might slide out during externalization. The same problems also may occur during externalization of a polypropylene suture for flanging. To overcome these problems, we designed a new instrument that combines the function of a needle and the function of a forceps. In an in vitro setting, we demonstrate the device. By activating the handpiece, the forceps glides from inside the hollow needle at the front and opens, grasps and retracts if the handpiece is released. Here you see the mode of action. By pulling the IOL at the haptic-optic junction, safe fixation of the haptic end is demonstrated. After implantation of a 3-piece IOL and marking of the fixation sites, the forceps needle creates an approximately 2 mm long scleral tunnel 2 mm from the limbus. Then the haptic end is grasped, externalized and flanged. Now a second tunnel, 180 degrees to the first one, is prepared by the forceps needle. The trailing haptic end is externalized using the same bimanual technique. Finally, the IOL is centered and an intrascleral fixation of the haptic ends under the conjunctiva is achieved. The forceps needle may also be used for refixation of a 3-piece IOL luxated into the vitreous cavity. After pars plana vitrectomy, the IOL is lifted from the posterior pole with a vitreoretinal forceps. We now have two options. Utilizing a handshake technique, we directly can grasp the haptic end with the forceps needle within the vitreous cavity and externalize it through a 2 mm scleral tunnel. Or we first can position the IOL in the anterior chamber bimanually and start from there with the preferred scleral fixation. With both techniques, we just need 2 limbal incisions and avoid a main incision for an IOL exchange. The forceps needle may also be used for refixation of a 3-piece IOL within the capsular bag. After preparation of a 2 mm scleral tunnel with the forceps needle, the IOL is fixed with a second instrument. The equatorial capsule is punched, the haptic end grasped and externalized. Now the same procedure is performed with the second haptic. In this case, we think that a single needle may not work sufficiently, as capsular tissue might prevent smooth gliding of the haptic into a needle and sliding out from the needle due to tissue resistance during the externalization maneuver may occur. The forceps needle can also be used for refixation of a capsular tension ring IOL complex with the use of a 6-0 Prolene suture. First, the instrument perforates the sclera 2 mm from the limbus and a capsule behind the capsular tension ring. Then the first suture end is externalized and flanged. Now the second end of the suture is externalized in front of the capsular tension ring with the forceps needle. After flanging the second end of the suture, the IOL is centered without any sign of pseudophacodonesis. Cases with single-piece IOLs with closed loops or with eyelets may be refixated using the forceps needle and a 6-0 Prolene suture too. First, the instrument perforates the sclera 2 mm from the limbus and the capsule behind the IOL loop. Then the first suture is guided through posterior pole, loop and anterior capsule and is externalized and flanged. Now the second end of the suture is externalized in front of the IOL haptic with the forceps needle. The IOL is centered by pulling the sutures. After trimming the suture end, Moderate tension is applied and the suture is flanged. With this method, the second flange will glide behind the conjunctiva and tenon layer and stop at the outer scleral ostium just like a plunge. The forceps needle facilitates 4-point suture fixation too. A 6-0 Prolene suture is positioned through the first 2 leading haptics. After scleral perforation, the first suture end is grasped with a 30-gauge forceps needle, pulled through the sclera and secured. Then the second end of the suture is treated in the same manner. The lens is folded and implanted through a 3 mm incision. Both trailing haptics are secured using a 6-0 Prolene suture again. Then both suture ends securing the 2 trailing haptics are grasped and externalized with the same forceps needle. The sutures are tightened and flanged. Care is taken to hide the sutures under the conjunctiva and the tenons layer. Due to the 4-point fixation of the IOL, perfect centration is achieved. The forceps needle was designed to overcome some of the shortcomings experienced with intrascleral haptic or suture fixation utilizing a needle technique. The instrument combines the option of tissue perforation with grasping of material such as IOL haptics and sutures, and it facilitates its manipulation. Surgical techniques that combine perforation, grasping and externalization of IOL haptics, sutures or other intraocular structures may be greatly facilitated by the presented instrument, even in cases with reduced visibility of intraocular structures. The forceps needle is a helpful tool for the refixation of IOLs and capsular tension rings with a double flanged suture technique, and for primary scleral IOL fixation, no matter which flanging technique is preferred. In the future, the forceps needle may be utilized for different intraocular maneuvers in anterior and posterior segment eye surgery.